If you're interested in medical or hospital social work, you may be wondering what the typical day looks like for a hospital social worker. In this video, I will discuss what you can generally expect a day of a hospital social worker to look like. My name is Tabby. I'm an LCSW with over 12 years of social work experience in the healthcare field. I'm here to bridge the gap between what you learn in social work school and real world experience. So I have worked in several different hospital systems over multiple states, and what I have learned is in general, the setting and the pace is pretty much the same, no matter what hospital you go to. What I'm going to share with you is how I typically structure my day when I work in the hospital setting. Your day might look a little different. It depends on how your hospital does things and how your department functions. So I have mostly worked a normal 8 to 4:30 Monday through Friday shift in my hospital career. However, I've done a couple of other things like the emergency department, and I've picked up some extra swing shifts here and there with different departments and different units. I arrive at work usually around 8 a.m. And after setting down my stuff, I log into my computer and I print out my census for the day. The census sheet is the list of patients that you are assigned to depending on how your hospital functions and your department functions. Some hospitals will assign you to a specific unit or a specific floor. Some of them will assign you to a specific team, and some you will just be randomly assigned. It just kind of depends how your hospital functions. So the very first thing that I do after I print my census sheets is I do a brief review of the patients that are on my list. I identify who the new patients are that maybe came overnight, and I look at the patients that I didn't get to the day before, and I look to see who could possibly discharge. I notate everything and make myself a to-do list. I also take a look at my calendar for the day to see if I have any expected meetings or appointments with families and patients. Everyone kind of structures their day differently. So I try to do a brief chart review on my patient list before we have a huddle meeting that typically starts around 9 a.m. Again, it depends on the hospital that you work at and their structure. But I like to look at my patients before I go in so I have an idea of how I can contribute to the team's discharge plans. So these huddle meetings, which are also sometimes called rounds, are when the interdisciplinary team gets together and we discuss patients, we discuss their discharges and potential barriers, and we kind of collaborate together to help meet the treatment and recovery needs of the patient. And that includes discharges. So the interdisciplinary team, which I've discussed in a previous video, usually consists of a social worker, case manager, the hospitalist or attending physicians, nursing staff, rehab therapists, pharmacists, chaplains, etc. So depending on the hospital, sometimes case managers and social workers will lead the huddle, and other times it might be the physicians that lead the huddle. It just depends. Some places do bedside rounding, and this is when the team goes to each patient's room together and we talk to the patients. We talk about their diagnosis with the patients. We do go over their medications, the assessment, and plan with the patients at bedside. This is kind of nice because it gives you the opportunity to hear what the rest of the team talks about with the patient. So then that way later, if the patient has questions that they didn't have a chance to ask, you can kind of help address those and everybody can be on the same page. At one hospital, we used a red, yellow, green method. And so what that was is the nurse or the hospitalist would go over each patient and identify whether or not they thought they were red, yellow, or green. Red obviously meant that they were not ready for discharge at all. Yellow meant that they might be ready for discharge, but it's conditional depending on a certain result of a test or maybe a consult to sign off on. And green obviously meant they were ready for discharge and they're ready to go and going to have discharge orders today. The meetings can typically take, I would say, around an hour, sometimes longer. So it depends on how your team functions and how quickly they go through things. I have had sometimes where the rounds will only take 15 minutes to 30 minutes, which I think is preferable, but again, it depends. And if you're doing bedside rounds, then it's going to be a lot longer because you're taking the time with the team to go and meet with each individual patient. Those ones typically took like 2 hours of my day, sometimes longer. So prioritizing my day looks like this. I first work on the discharges first, the active discharges. So typically what we call the green patients, who we know are going to discharge today and have discharge orders. So I'll work on those patients first. After those discharges, then I'll work on the patients who could potentially still go the same day or the next day. And I'll work on their discharge plans and getting their stuff together for potentially discharging. And then after that, I'll work on my assessments and do some follow-up. I often reprioritize my tasks throughout the day because things come up that might take precedent over something else. And discharge plans are constantly changing. So you have to be flexible and be ready to change the plan and change your day instantly. So, of course, as social workers, we have to document, good old documentation. And I prefer to document right after I see my patients if possible. Some hospitals, you might have the ability to have a computer in the room or have a laptop that you can carry with you so you can document as you are meeting with the patient or really immediately right after you see the patient. Other hospitals, you might not have that luxury. So that's why I always take my census list and I make notes on that list while I'm talking to the patient. When I first started out, I actually created myself a template of the questions I needed to ask patients. And I used that to make my notes on when I talked with the patients. So then that way, when I got back to the computer, I wasn't missing anything and I didn't have to go back to the patients and ask those questions again because that's very time consuming and you don't have a lot of time throughout the day. It's very fast paced. There are also times where I couldn't see the patients when I wanted to. Maybe they were in a procedure for testing, or the doctor was seeing them, or family was with them and they didn't want to meet at that time. So then I had to reprioritize my day again. And so I would go back at a later time to see if I can meet with them and try to get that assessment done. So staying organized is going to be very important for a hospital social work job. And it's important for you to know that some hospitals you might have a specific office. There were hospitals that I worked in where I had a specific office for social workers, or I had my own office as a social worker, or I shared with someone on the unit or the floor I was on. Other times I was in a bigger office with multiple case managers or social workers. And then other hospitals, I actually didn't have an office at all. And so I kind of had to create a more mobile office. And so I had to use the computers that might be available in the common areas where physicians and nurses were using them to document as well. So to create a mobile office, I often kept an organizer with me, and a couple of them that I used look like this one and this one. And what I did was I kept the resources and Medicare letters and things that I needed to give to patients in these organizers. So then that way, I didn't have to go back to a computer, print papers out, or go to a filing cabinet and print papers out to go back to the patient room and give to them. I had them ready to go in my organizer, then I could give it to them on the spot. I also kept lists of home health agencies and skilled nursing facilities with me, along with a list of health insurances that accepted certain agencies or facilities to give to patients so that it can help them make their decisions, and I can try to get the discharge plan going sooner than later. So as a social worker, you're a discharge planner essentially. You have to come up with discharge plans, plan A, plan B, plan C, all at once. So I let them know that my goal was to help make sure that they had a smooth discharge plan, and that discharge planning happens the day of admission. I think people don't realize that. So I would go into their rooms, I would introduce myself, and I would let them know that although they're not discharging today, it's important for me to start the discharging planning now, so then that way we're not running around at the last minute trying to figure out what to do. So I let them know what potential discharge plans could be. I let them know that it could potentially be that they could go home and not need anything, or it could potentially be that they go home and need home health services, or that they might need to go to a skilled nursing rehab. So I wanted to make sure that we planned for all of those options. And so I go over the list and what those options are with them and have them pick out what they would want and if the case scenario was either of those options. So there are also going to be different meetings that you're going to have to attend, such as a lot of places you have to do a weekly length of stay meeting. And I'll do a separate video to kind of go over what length of stay is, but essentially it is going over the patients that are over like 3 days that they've been in the hospital, but I'll go over that in another video. And then you also will have monthly department meetings, sometimes more frequently, depending on how your department functions. And then there's continuing education meetings or classes that you might have, as well as other hospital meetings. So that's why I look at the calendar at the beginning of my day to kind of see what meetings there are. Some meetings I can get to and some I can't. It really is just going to be a matter of what my day looks like and how I can reprioritize and what emergencies come up. At my end of the day, I look at any patients I wasn't able to see or anything I wasn't able to get done during my 8-hour work shift, I will save for the next day's to-do list. I always start and end my day with a to-do list to help me keep track of things, and I cross things out as I get them done. If you sign up for my newsletter, I can send you what my to-do list kind of looks like. I kind of have like a planner page that I set up for myself to help me keep track of my day and organize my to-do list. One thing that's really important is to keep strong boundaries. There are so many social workers, and you might be one of them, I was one of them, where we feel like we have to get everything done in this 8-hour day. And we feel like if we don't get it done, we're letting our patients down or we're letting our colleagues down, which is not actually the case. The thing is that there is almost nothing that can't wait until the next day to get done. So spending an extra 2 hours in the hospital isn't necessarily going to mean that you have less things to do the next day. There's always going to be more. So that's why it's important to keep strong boundaries and just know that just because you didn't get something done today isn't the end of the world. A patient isn't going to die because you didn't get their discharge plan done today, or because discharge orders were in and you weren't able to get their transportation set up. I personally would much rather have the patient stay in the hospital where I know it's safe and wait until I can get a good, safe discharge plan in place and transportation set at the right time and everything goes together than to try to stay extra and hope that I can get them done, get that patient out in the amount of time that the hospital wants me to, and it end up being an unsafe discharge for that patient. So I will usually talk to my team and let them know, hey, if orders aren't in by this time, or if things are not completed that I need to be completed by the team by this time, the patient isn't going to go today and it's going to have to wait until the next day. So, but you have to feel confident enough to be able to do that and communicate with your team. But it's super important that you do that. Hospital quotas are just quotas. So hopefully this gave you a general glimpse of what a day looks like for a hospital social worker. Please follow and subscribe to the channel if you want to learn more about hospital or medical social work. Also, please sign up for the Medical Social Work Mastery newsletter to get emails on tips, tricks, and resources on how to become a more efficient medical social worker.